The physicians of the Massachusetts Medical Society are involved in this effort because we share the belief that coordinated care is better than fragmented care. We want to support innovations that move us in that direction. It's better for the patient, and it's better for our healthcare system. That's why we believe that studying new ways to pay physicians in hospitals is worth pursuing. But, and there's a big but here, that has to be approached carefully and deliberately. While there are pockets of innovation around us, I think Secretary Kern mentioned that 20% of physicians are now covered by global payments. The kind of transformation and vision here statewide has never been done anywhere in this country on a system-wide basis. For that reason, there are many unknowns and unanticipated and unpredictable effects that could happen when you try to expand its scope and application. For that reason, we are strong, very strong, advocates for establishing pilot projects for these innovations. They don't have to take very long. They can't. We understand the problem. But we need to test the many approaches to this issue on a limited, controlled scale. We need to uncover the unintended consequences and learn from our mistakes and adjust to them before it's rolled out to larger sectors of our population and have a disaster unfold on health care delivery in the state. I just found out today, as an addendum, that another primary care physician in my hospital quit practice and became a hospitalist. If we move too quickly and rattle the tree too abruptly, you're going to have physicians fall out of their practice like leaves out of a tree. What model works best for Massachusetts? Will they save money? If so, how much? What's the impact on quality or access? Will patients trust it? And will many physician practices that are currently on thin ice financially survive the new models? We don't know the answers to any of these questions. That's why we need pilots first. We will be there to help make sure they succeed, however. Physicians do want change. Further, very few physicians today could make a successful transition to a new payment model right out of the gate. And I frankly believe that 5 years probably won't be enough for the majority for this job to be done. There's too much diversity in our healthcare system to impose a simple model on anyone. The needs, dynamics of praxis, and resources of praxis based in urban Boston are very much different than, say, Berkshire County or Cape Cod. Imposing a single model in all these three diverse regions is unlikely to achieve the same result in all three regions. To make that as a baseline assumption would be a huge mistake. We understand the urgency of the cost issue, but if we move too fast, many physicians won't be able to keep their practices open, and shortages that we experience, not just in primary care, but in many specialties, will only get worse. We already had some physicians in my talks around the state say they're watching this very closely and are making plans to leave the state if their worst fears materialize. I keep trying to reassure them that we're going to make it right and that you will make it right. Having said that, many of these practices are currently struggling to stay afloat now. We can't roll out a new payment system statewide unless we know the answers to these questions. Finally, we cannot focus on payment reform as the only answer to the state's healthcare problems. Even if it could be implemented successfully and expediently, a big if, focusing on the small fraction of healthcare dollar that is spent on physician services is not going to get the entire job done. You heard Inspector General Sullivan speak just a little while ago. He mentioned that Blue Cross Blue Shield has had a 40% increase in 3 years. 10% is proposed for this coming year for premiums for the citizens of Massachusetts. Of that, do you know how much is going to physicians? 0. So we're not the problem here. Physician fees are about 20% of the healthcare pie. If every physician in the state worked for free for the rest of their lives, you would get about a 2-year reprieve in this relentless cost spiral. So you got to look at other areas. It can't just be freezing fees. There are other factors we need to address. Patient education, patient expectations, compliance issues need to be understood and addressed. Wellness and prevention initiatives. Dolores Mitchell mentioned that, and I agree with her. A healthy lifestyle and proper preventive care can lead to enormous savings and certainly a better quality of life. We need to focus on that. Defensive medicine. Many studies have shown this to be a significant driver of costs, from our own survey of 1,000 physicians to the independent Pricewaterhouse National study that show a potential of, in this state, $1.5 to $3 billion savings in the state and $250 billion nationwide. I point to real proven success in Michigan, whose apology approach legislation we want to emulate here in Massachusetts, that Senator Moore, thank you, is sponsoring. I have to say the denial of this issue by many legislatures when this topic is brought up is a source of continued bewilderment and consternation to many physicians in the state. Like it or not, it is a driver of costs. Let me make this point dispel a widely assumed myth that most doctors make more money by ordering more tests. The vast majority of physicians make not one penny by ordering a test. They do not own the equipment, and there's no fee splitting. ER docs and independent practices do not earn more by ordering an MRI or CAT scan. Radiologists who do earn the fee don't order the test. So to make the false assumption that it is fee-driven without ignoring the real drivers of increase in testing will defeat reform. Administrative waste. The insurers in the state claim overhead of 11 to 15%. In this state, nationally, it's claimed to be 25%. The truth is somewhere in those numbers. There are many administrative simplifications that could slash that figure for substantial savings. The overconcentration of our health insurance industry. We have 4 major insurers in the state. One is very dominant. They have antitrust exemption by law, yet physicians are specifically prohibited by antitrust laws to negotiate. Therefore, while some large healthcare systems can bargain forcefully and have grabbed newspaper headlines, as I'm sure you've noticed, for the average small practice, this is not a level playing field. The contracts are typically take it or leave it, with one insurer dominating 50% of the market. Saying no means basically close your practice. There are several mandates before the legislature that would add even more cost. They are pushed by special interests and legislators who I know genuinely want to help a specific constituency. However, many of them are not based on science and would only add to the problem by driving up premium cost. I urge you to basically say no to any more mandates. We have to keep costs under control. The issues are varied and complex, so the solution must be complex and nuanced, if not more. As I said, physicians are committed to working with you on these issues. We will bring to the table energy, creativity, and most of all, the direct experience of caring for our patients. We want healthcare reform. There isn't a physician in the state that I've spoken to who wants a change from the current system. Having said that, I'll either ask for questions or I'll turn it over to Alice Coombs.